So good evening to everyone. So I like to again welcome you in the world of NEET PG exam, where we will help you to crack NEET PG. And so let's crack it, NEET PG. And basically I am Dr. Anil Sharma, and I am Dr. Anil Sharma, and I am a MD pathologist from AIIMS. Okay, I am a MD pathologist from AIIMS. Basically, so before taking you to the world of Unacademy, I'd like to say you how you can subscribe to our Unacademy. Okay, so for subscribing, what you need to do, you need to install the Unacademy learning app. So this is the Unacademy learning app, and you can install this Unacademy learning app. And what can you do after this? Just you can just subscribe for either you can get a plus subscription or iconic subscription. Okay, so the benefit of plus subscription is basically you get live classes there, you can get live test and quiz, you are getting batch courses and structure schedules. Same thing you will get in iconic subscription also, but in iconic subscription what you have one more app or one more additional thing, that is prep ladder. Okay, so now this prep ladder, they also have video lectures, so you will get all those video lecture, you will get handwritten notes, one of the very much important thing, handwritten notes of toppers. Then you will get question bank. Okay, these are the past year collected questions of different NEET and INICT, that is AIIMS, PGI and NIMHANS. Okay, then also there is another important thing, that is the rapid revision course you will get. And obviously the videos which we make at Unacademy, there also we regularly make videos where I have also made one compiled pathology course video also. So similar videos we make. Similarly, the other teachers, they are also making, there are a lot of teachers related to pathology, and they are also making their compiled videos. So that rapid revision you can see. And obviously images. Now image based questions are very, very important, because we can teach various images, or we can show various images to you by live classes, and that becomes very easy to understand or grasp the topic matter. Okay, and plus the teachers. Okay, so these are some of the very, very obviously mentor over here in this app, basically at Unacademy. So you have Dr. Zainab Vora. So I feel like her teaching is best among radiologists. So if you learn something from her in radiology, that's over. If she said something is going to come in your exam, you are going to get that thing in your exam. Similarly, Dr. Preeti Sharma, I have seen her some of videos, and she's a wonderful teacher who teaches pathologists. Okay, and obviously her special class are wonderful. Dr. Pawan Kandhari and G. Rajesh have also similar way of teaching, conceptual teaching, so your concept can be made clear. Okay, so now you can subscribe. So for NEET PG iconic subscription, the price basis are 55,000, 60,000, 77,000, 90,000 when you don't apply promo code. When you apply promo code, like my promo code is Anil Live, so when you apply this promo code, you are going to get 10% flat discount, which gives you the 12-month subscription at 49,500. This comes out to be at 4,125 rupees per month. Okay, 4,125 rupees per month, which is nearly about 140 rupees per day. So this isn't a very big price. Okay, this isn't a very big price, because lot of amount we expand in chai sutta. I'm just joking anyway, but what you can do is basically you're going to get subscription. Obviously prep ladder also you are getting in this, and that is a plus point. Okay, and we also have plus subscription, which is around, which you can take 1 month, you can take 1 month, 3 months, 6 months, 12 months, 18 months, 24 months and 36 months. Now this 36 month if you take 24 month subscription, and with my promo code Anil Live, you are going to pay 36,000. You are getting a discount of 10% discount, that is around 4,000 discount, which is around 1,500 per month. Okay, so this 1,500 per month just comes out to be 50 rupees per day, which is again a very important. Just you are spending 50 rupees and you can get daily live videos, plus you can interact with the educators. So that's a wonderful option for you all, and let's crack it. And together we can, in this world of Unacademy, we can help each other. I can help you to crack NEET PG, obviously, and you can help me to improve more and more, and so that I can help more and more people. So that way we can help each other. So let's come to today's topic. So I have been talking about renal disease, and we have talked about different diseases. Okay, we talked about post streptococcal glomerulonephritis, we talked about nephrotic syndrome like minimal change disease or focal segmental glomerulosclerosis, we talked about lupus nephritis. Okay, we talked about membranous glomerulopathy, and we have talked about membranoproliferative glomerulonephritis and C3 glomerulonephritis. Most of the glomerulonephritis we have already completed under this channel, okay, at Unacademy. Let's crack it. So now, what Unacademy PG NEET, let's crack it. So now today I'll be just going to another type of glomerulonephritis. This is also cause of primary glomerulonephritis. Okay, this is also cause of primary glomerulonephritis. When we divided glomerulonephritis, as I said, there can be primary glomerulonephritis and secondary glomerulonephritis. Okay, primary glomerulonephritis means the main etiology is in the renal. Okay, and secondary glomerulonephritis matlab you are getting the etiology is somewhere outside the renal, like in lupus nephritis. Okay, in endocarditis associated glomerulonephritis. Okay, deep seated abscesses and all, there are basically you have the secondary cause of lupus, you have secondary cause of nephritis. Okay, so crescentic or rapidly progressive glomerulonephritis. Okay, so clinically we say it as rapidly progressive glomerulonephritis because it within 1 to 2 weeks, basically it starts after the beginning, within 1 to 2 weeks it progressed to the end stage. Okay, so end stage renal disease, it progressed to end stage renal disease, hence it is called rapidly progressive glomerulonephritis. Okay, so basically that's why it is characterized by rapidly relatively rapid and progressive loss of renal function. Okay, so basically there will be loss of renal function, and it will be going towards the end stage renal disease. Now going towards the end stage renal disease will implies that you are going to get oliguria, severe oliguria or anuria. Okay, now basically if it is not treated, then there can be death from this renal failure within weeks to months. Okay, now basically this crescentic this is associated with glomerular injury. Okay, glomerular injury, but it doesn't denote a specific etiology. There is no specific etiology, but the major concern in crescentic glomerulonephritis is the glomeruli. Okay, major concern is glomeruli. Okay, so this is important regarding crescentic rapidly progressive glomerulonephritis. Now, as I have again and again explained that rapid progressive glomerulonephritis, the main thing here in crescentic glomerulonephritis. Okay, so basically people write it CGN also, crescentic glomerulonephritis. So in CGN, basically in CGN the main thing is crescents. Okay, so the ultimatum is the crescent formation. Now we have already discussed about the crescent, that crescents can be cellular crescent. Okay, they can be fibrous crescent. Okay, and they can be fibrocellular crescent. So this can be different types of crescent which you get in your studies. Okay, so what are these crescents? So these crescents are the most common histological picture, and the presence of crescent basically in the glomeruli defines this crescentic glomerulonephritis. But again, more deeper, when you go more deeper, no, then you can say that this is a crescentic glomerulonephritis when your crescents are more than 50%. Okay, mostly crescentic presentation is more than 50%. Like if you have only 15% of crescent present and you are diagnostic basically like anti-GBM glomerulonephritis, then you don't say it's crescentic anti-GBM glomerulonephritis, you rather say it anti-GBM glomerulonephritis with crescent. Okay, so crescent normally you need to have greater than 50% of crescent, so that is one criteria. Basically that from your point of view it's not that important. From your point of view, what you need to know is you need to know crescent. So crescent, basically when I say crescent, the early crescent, okay, you have early crescent. So early crescent will have monocytes as main cells. Okay, monocytes as main cell. So as I said, I already explained that crescent are just basically the proliferation of parietal epithelial cells. Okay, so those parietal epithelial cells in the Bowman's capsule, so Bowman's capsule have parietal epithelial cells. Those parietal epithelial cells, when they proliferate, they will form crescents. Okay, so those crescents will have also monocytes and macrophages and other types of cells, and in that early crescent will have monocytes, and the late crescents will have more of parietal epithelial cell proliferations. Okay, parietal epithelial cell proliferation. So here it has been written again, it is produced predominantly by proliferation of epithelial cell lining the Bowman's capsule. Already we said that this is basically, if this is your PCTs, and this is your Bowman's capsule. So this Bowman's capsule, so this is Bowman's capsule, this will have your parietal cells. Okay, these are the parietal cells. So these parietal cells, when they proliferate, obviously they will form crescent. So now when this parietal cell proliferate, what should happen? What should happen if you think logically? What should happen? So this is the Bowman's capsule. Okay, this is the Bowman's capsule. There should be disruption of this Bowman's capsule. Okay, यहाँ पे disruption होना जरूरी है. So basically normally in crescent, what you see disruption of Bowman's capsule. Okay, you will see disruption of Bowman's capsule. So that is another very important point in case of crescent formation. Okay, so if there are no disruption of Bowman's capsule, then that is not a crescent. They are confusing with adhesion or other type of cellularity. Okay, and they are infiltrated by monocytes and macrophages. So this is what I have already explained. Now coming to the cellular crescent, as I said, obviously you have cellular crescent. So this crescent are, so here you can see basically, so this is a fibrin deposition. This is a fibrin of, you can see fibrinoid necrosis very commonly in a crescent, and this is a crescent. Okay, this is a crescent. So here you can see there is Bowman's capsule disruption, and obviously this area is showing a crescent. This area is showing a crescent. Again this area, again there is a disruption of the Bowman's capsule, and this area is showing crescent. Okay, so crescent is basically epithelial cell proliferation, Bowman's capsule epithelial cell proliferations. Okay, so this is basically, you need to know crescent. Now crescent is basically you need to there should be presence of more than 2 cells in the Bowman's space. So this is the Bowman's space. इसको Bowman's, ये Bowman's capsule है, तो इसको Bowman's space बोलेंगे. तो यहाँ पे more than 2 cell layers अगर आ जाता है, ओके, ये अगर ये जैसे ये epithelial cell है, बेसिकली parietal epithelial cell, so ये parietal epithelial cell अब यहाँ पे proliferate होके इधर आने लग गया, तो basically that is what you call it crescent. Okay, that is what you call crescent. Now basically crescent होगा तो obviously the capillary formation and the filtration में difficulties होंगे. There will be problem in this filtration process, and there will be problem obviously in these capillary loops. Okay, and hence there will be tufting and all, the problem of filtration and all can be seen in case of crescentic glomerulonephritis. As I said, there can be another type of crescent, that is fibrous crescent. Okay, so fibrous crescent is having a lot high amount of fibrin deposition. Okay, lot high amount of fibrin deposition, that is obviously fibrous crescent. Okay, so basically if this is a fibrous crescent, and obviously you can have fibrocellular crescent. So see, this is basically your crescent. This is basically your crescent. So this completely a crescent. This is a glomerulus. Okay, so there are glomerulus, and it has a cellularity also, high cellularity, and it has also fibrous content also. Okay, so this is basically showing you fibrocellular crescent. Okay, so that's it, a fibrocellular crescent. Crescent basically, so glomeruli, so crescent shape. Okay, like moon, crescent moon. So this is forming a crescent shape, no? So यहाँ से लेके ये देखो, ये क्रिसेंट का शेप जैसा दिखा रहा है. सो दैट्स वाई वी कॉल इट क्रिसेंट. ओके, दैट्स वाई वी आर कॉलिंग इट क्रिसेंट. सो नॉर्मली दिस इज नॉट हार्ड एंड फास्ट रूल कि क्रिसेंट बनाना ही है, बट या दैट्स वाई वी आर कॉलिंग इट अ क्रिसेंट. ओके, सो दिस इज बेसिकली योर ग्लोमेरुलाई. दिस इज बेसिकली योर ग्लोमेरुलाई, एंड दिस इज फ्रॉम पैराइटल एपिथेलियल सेल इन द Bowman's space. Proliferation of parietal epithelial cells. Okay, so easily it is explainable. Okay, it's not difficult now, so you can understand. So these are the crescents. Now nobody is going to ask you they will give you the figure and say कि diagnosis का diagnose करो, कोई नहीं, but I am providing you this figure because now just make this photograph or this, take the image in your brain. Okay, अपने brain में इसके image ले लो. Obviously this makes it makes easy for you to grasp, आपको grasp करने में easy हो जाएगा. Okay, so now coming to so we are talking about crescent. So I said about the crescent, what are the crescent, and obviously crescentic glomerulonephritis, the hallmark are crescent. Crescents are the hallmark, but remember crescents can be present in other diseases also. It's not necessarily that crescent can't be present. Crescent can be present in IgA nephropathy, in post-streptococcal nephritis. Okay, in membranoproliferative glomerulonephritis, crescents are present, and hence like type 2, that is immune complex, immune mediated जो C3 glomerulonephritis, sorry, C3 crescent glomerulonephritis होती है type 2 में. So this all like IgA nephropathy, membranoproliferative glomerulonephritis are included in that. Okay, you need to know that. So basically, what is the main pathogenesis of this crescent or crescentic glomerulonephritis? So main pathogenesis is basically it is immunologically mediated. Okay, so this is manifestation of number of diseases, number of different diseases. Some are restricted to kidney, some are coming from systemic diseases, but basically immunological mediation is basically one of the important and thing which occurs in case of crescent. Okay. So now you can classify it accordingly like type 1, type 2 and type 3. The major way of classification is by immunofluorescence. Okay, this is classified by your immunofluorescence. So deposition of anti-GBM antibody, or you can say linear capillary deposition. Okay, then another is, second one is immune complex, or you call it granular deposition. Okay, granular deposition. And third three are pauci-immune deposition, or basically you call it no immune deposition. There is very pauci-immune deposition, or लगभग ना के बराबर immune deposition होता है. So now this is important thing which you need to know in case of what do we call it, in case of C3GN. Okay, crescentic glomerulonephritis, very much important. So basically type 1 are basically Good's-Pasteur syndrome. Okay, type 1 can be Good's-Pasteur syndrome. So when I talk about type 1, okay, when I talk about type 1, so type 1 is basically your Good's-Pasteur syndrome. Type 1 is Good's-Pasteur syndrome. Okay, so when it is involving your pulmonary hemorrhage. Okay, so जब आपका respiratory system भी involve कर रहा है plus with renal system. Okay, kidney system with renal system or glomerular system आपका involve हो रहा है. So this is respiratory system. Here you will be having pulmonary hemorrhage. Okay, you will be having pulmonary hemorrhage. Okay, pulmonary hemorrhage. Except like pulmonary hemorrhage, clinically it can show you hemoptysis. So clinically it can show you hemoptysis. So this is major feature which you say in case of Good's-Pasteur. But like there can be isolated anti-GBM antibody glomerulonephritis also. There can be anti-GBM glomerulonephritis भी हो सकता है. Okay, this you need to clear, you need to know this about. Okay, you need to know this thing, this is very much important. So there can be anti-GBM glomerulonephritis भी हो सकता है. Okay, so this is an important thing you need to know. Then in type 2 it can be idiopathic, is major cause. Then there can be like post-infectious glomerulonephritis, lupus nephritis, HSP, IgA nephropathy and others in these immune complexes, even MPGN. Okay, they can be. Then type 3 is basically pauci-immune. So type 3 is basically pauci-immune. So what you need to know about type 3 is, so type 3 is basically pauci-immune. So when I talk about pauci-immune, I should know that it is basically NK associated. It is NK positive, very less NK negative. So mostly it is NK positive. Okay, mostly it is NK positive. Okay, and it can be idiopathic. So NK positive, basically it can be granulomatosis with cholangitis like Wagner's granulomatosis. It can be microscopic cholangitis, or it can be granulomatosis, eosinophilic granulomatosis with cholangitis. Okay, it can be eosinophilic granulomatosis with cholangitis. Okay, so this basically is Churg-Strauss syndrome. Okay, so this is Churg-Strauss syndrome, Wagner's granulomatosis or microscopic cholangitis. So these are pauci-immune glomerulonephritis. These are associated with pauci-immune glomerulonephritis. Okay, so this classification is again very necessary, because in NEET PG a direct question can be asked in which of the following is NK positive or pauci-immune glomerulonephritis, or which of the following does not includes in NK positive pauci-immune glomerulonephritis. Okay, so they can ask this question directly. This question can be asked in your exam. Okay, that you need to know. So this is very much important thing which we need to know. Now this is as I said, obviously rapidly progressive glomerulonephritis is divided according to your IF. ओके, वो इम्यूनोफ्लोरेसेंस के हिसाब से डिवाइड किया जाता है. सो अकॉर्डिंग टू IF, सो सपोज दिस इज योर IF. So what you can see, basically I have shown lot of images regarding IF. So now basically you can show these are the capillary loops. Okay, these are the capillary loop, and here you can see linear capillary. Obviously you can see linear capillary proliferation deposition in this. Okay, so immunofluorescence. So this is basically your anti-GBM. This is basically your anti-GBM anti-GBM glomerulonephritis. Now this is type 2. Here you can see this this had tone granular है, ये तो अच्छी तरह से दिख रहा है. So this is basically your granular deposition. So granular deposition, this occurs in where? So this is basically occurring in type 2. This is occurring in type 2 immune complex. Okay. Now come towards this. So here there are no immunofluorescence is negative. Immunofluorescence is negative. Immunofluorescence is negative here. So this is basically third type, that is pauci immune. Okay, this is pauci immune. So pauci immune. So you can also they can show this image A, B, C. Okay, A, B, C, and which of the following is correct statement. They can ask you which of the following is correct statement. So the question can be like, in exam you can be given this image as A, this image as B, this image as C, and which of the following is correct statement. Which of the following is correct statement. Okay, then just they can give you A, like they can give you A can be given like what they can give you. So they can give you type 2, okay, B like type 1, and C like pauci immune. Okay, then they can give you another option like A type 1, B type 2, C pauci, or they can give you A pauci, 2 type 2, B type 2. So that way correct option को tick करना है. So obviously this will be the your right option, type 1, type 2, type 3. So this is type 1, this is type 2, this is type 3. So they can ask you in exam this way also, very easy. But if IF देख के डर गए तो obviously you can't solve it. So this is very important thing over here. This question can be asked in your exam regarding obviously rapidly progressive glomerulonephritis. Now coming to anti-GBM antibody mediated disease. Okay, so firstly we'll talk about the type 1. Type 1 are basically they are characterized by, so this line is very much important क्योंकि इनका classification is basically related to IF. So they are characterized the linear deposit of IgG and in many cases C3 in GBM. So anti-GBM is characterized by linear deposit, and as I said IF when I was teaching you about IF, I said you that you just remember DAD is MLA. So when you remember DAD is MLA, so this DAD part is your linear capillary, each part is your mesangial basically granular, ML part shows your coarse granular capillary wall, and A is basically your diffuse type of capillary wall and mesangial. Okay, so these are this part. So your DAD basically DAD have this, A is anti-GBM. Okay, this is diabetic nephropathy, this is dense deposit diseases, and obviously D is deposit, that is MIDD. Okay, monoclonal immunoglobulin deposit disease. So basically your A, this is basically your anti-GBM disease. Okay, so basically you can by now you know very well that linear deposit of IgG and C3 is you can see in anti-GBM disease. Okay, so now whenever this anti-GBM antibodies, if they cross react with pulmonary alveolar basement membrane, then that condition you say it is Goodspasser syndrome, or else you say it is anti-GBM glomerulonephritis. Okay, if it is not associated with pulmonary hemorrhage or it is not associated with lung, then obviously you don't say it Goodspasser, or else whenever it is associated with lungs, then you say it is a Goodspasser. Okay, so pulmonary hemorrhage, renopulmonary syndrome. Okay, this is part of pulmonary hemorrhage associated with renal failure. Okay, that need to be understood very well. So now what you need to remember, another thing is that main etiology is basically here you have antibody is against. So antibody is against, so against the basically antibody is against the non-collagenous part. So this is non-collagenous part, domain of alpha 3 chain collagen 4. Okay, non-collagen part of alpha 3 chain collagen. So this is basically a epitope antibody against this new epitope. Okay, so new epitope against non-collagenous 1 alpha 3 collagen basically chain, 1 alpha 3 chain collagen chain. Okay, so this is known as Goodspasser antigen. So this can be your MCQ which can be asked in your exam. So this etiology you need to remember. Okay, so remember this, that GBM disease can be your one, it can be anti-GBM glomerulonephritis. Okay, and it can be Goodspasser syndrome. That you need to know. Okay, that you need to know. In this Goodspasser syndrome there will be renal plus lung syndrome. Okay, there will be renal involvement and involvement of lung. That is another important thing you need to know. Okay, now the risk factor, basically the risk factors of or those factors which will generate this antibody is basically are like hydrocarbon exposure, cigarette smoking, and most of the HLA-DRs. Okay, certain HLA-DR like HLA-DR-B1, HLA-DR-B1 and DQ antigens. Okay, so these antigens, they can also generate this antibody. Okay, no, and NC antibody against collagen alpha 3 chain of collagen 4 alpha 3 chain of collagen 4 at non-collagen 1 domain, against alpha 3 collagen 4. Okay, alpha 3 chain collagen 4. So this antibody against this, they generate this way. Okay, cigarette smoking, HLA, or this can, okay, even exposure to viruses. Okay, exposure to virus also can result into antibodies. Okay, against GBM, antibody to against GBM, and also the complement pathway, the complement mediator, complements can also result this development of this antibody. Okay, so this is basically main pathogenesis of this disease. Now coming to so I've already explained about the GBM disease. Okay, I've already explained you about the GBM disease. Now coming to the next thing. So this is basically your integration to, I'm just integrating to immunology chapter. Okay, general pathology, immunology. So basically when something comes about general pathology, always उसी time में उसको revise कर दो. That is very very important. So how can, what do you need to know about in general pathology? So where do MHC lies? So MHC lies in chromosome 6. So this is an MCQ, बहुत बार पूछते हैं, direct question आता है. Okay, MHC कहाँ पे lie होते हैं? So MHC के types. Okay, MHC region have 3 genes. Okay, MHC class 1, MHC class 2, MHC class 3. Okay, so these are the 3 major genes which are present in a MHC region. Okay, at in chromosome 6. Okay, so MHC class 1, basically they are responsible for HLA-A, B and C. So these are HLA-A, HLA-B and HLA-C. Okay, HLA-B and C. Then MHC class 2 is responsible for HLA-D, which is HLA-DP, DQ and DR. Okay, so these are basically important. DP, HLA-DP, DQ and DR. So these are important, and obviously here we have HLA against antibodies against HLA-DR antigen. Okay, so now you also need to know about HLA antigen. So you just hereby you can just go back to your immunology chapter, just open your Robbins. Okay, there you can see different types of HLA. Okay, so you can see in MHC region it is class 1, class 2 MHC, class 3 MHC and cytokine genes, which some of the writers they write is as class 4 also. Okay, so TNF alpha and TNF beta are basically class 4 antigens. You can say they are class 4 MHC also. That you can say them as basically class 1 will have HLA-A, HLA-B and HLA-C. Next question which is asked is where is MHC located? Okay, so it is located in all nucleated cells except RBC. Okay, nucleated RBC में नहीं होता है. So this becomes your another MCQ. Okay, another MCQ, HLA class 1. Now class 1 is recognized by CD8. Okay, class 1 is recognized CD8, and CD8 is basically cytotoxic, यानी कि it will be responsible for destruction of abnormal or infected cell by cytotoxic T cells. Now class 2 are HLA-D. Okay, HLA-DP, DQ, DR, DP, DQ, DR. Okay, so these are responsible. DP, DQ, DR. And where these HLA2 are found? So these are found at B lymphocytes, monocytes, macrophages, dendritic cells. All your antigen presenting cells mostly are containing HLA2 class 2. Okay, MHC class 2. Okay, so this is again important, and obviously class 2 will be recognized by CD4, and that CD4 is responsive helper T cell. It acts as a helper T cell, you know very well. Class 3, they are the complements C2, C4 and complement B. Obviously they are the tissue location will be in the plasma protein, and obviously this complement they have a function of defense, and tumor necrosis factor alpha and TNF beta, this is responsible for cell growth and differentiation. So now this you need to know, or you, and also try to learn or see the structure of MHC class 1 and MHC class 2 in your Robbins. Okay, go back to your Robbins, at least इसको तभी देख डालो ताकि immunology का वो part आपका revise हो जाए फिर से इस topic से, ठीक है. So now coming to the again topic basis. So what are the clinical issue in GBM? So what are the clinical issue in anti-GBM? So basically the peak is in second to sixth generation, okay, decade, so 20 to 60 years of age, so this peak age you can see. So presents with acute kidney injury in greater than 90% of the cases, and 25 to 50% cases are associated with pulmonary hemorrhage, and this, if these both are present, then that is Boots-Pasteur syndrome, okay. So now very much important, you can treat this by plasma pheresis, okay. At antibody बना हुआ है तो plasma pheresis करके उसको wash out कर देते हो antibody को, okay. So basically, and you are also giving immunosuppression. So steroids, you can also use steroids. So these all are basically have a very good prognosis in anti-GBM glomerulonephritis, okay. So this is very much important, and poor prognosis is if creatinine is greater than 5 mg per deciliter at the time of diagnosis, and basically anuria also is a poor prognosis, that is again very much important. So remember, if Crescent is 75, more than 75%, then renal function recovery is very difficult. So this also greater than 75% of Crescent is also a poor prognosis for this disease, okay. So this is anti-GBM disease. I am talking about anti-GBM. I was talking about anti-GBM. You need to know these all things about anti-GBM disease, okay. Now let's come to the microscopic part of this. As I said, microscopy has nothing more to offer you. So I have already explained in crescentic disease that the crescent or cellular crescent is what it is most important thing, okay. And as I have already shown you, there can be fibrinoid necrosis, associated fibrinoid necrosis is also present in Crescent, okay. So, and already we have talked about the linear IgG and C3 staining of GBM. This is IF. So IF में ये दिखेगा, okay. So you can see this is the major type of immunoglobulin positive, but you can see other types also like IgG4. You can see IgA and IgM staining also you can see in these cases, okay. So this is an important thing. Now in CGN, that is Crescentic glomerulonephritis, see, remember the role of electron microscope. So electron microscope is not that much big anyway, but electron microscope you can see break in GBM. As I said, as I already explained, when crescent are forming, then obviously the glomerular basement membrane, or basically your this Bowman's capsule membrane, there will be breakage in that, okay. There will be disruption of that membrane, okay? And that thing you can see in electron microscope, okay. Otherwise it is normal. There will be no deposits in this case. So this is again a classical picture of Crescent. See, so that you can see this is a Crescent, okay, the classical picture of Crescent, beautiful Crescent, yeah, kitna beautiful Crescent. So this is a classical picture of Crescent. This is your glomeruli, this is your glomeruli, and obviously this Crescent, there is proliferation of parietal epithelial cells. So very important. So this picture is basically showing you this Crescent, okay. So this is GBM. So this is basically GBM. How? Not by that microscopy, but by this linear IgG deposition, okay, linear IgG deposition in GBM. So this is basically important thing, linear IgG deposition. This is also linear IgG deposition in GBM. So GBM in basement membrane, capillary. So linear IgG deposition in the capillaries, okay, linear IgG deposition in the capillary wall is what is most important for diagnosis of this crescentic glomerulonephritis, that is anti-GBM glomerulonephritis. Okay, so now coming to the another type of glomerulonephritis, that is pauci-immune crescentic glomerulonephritis. Okay, so when I talk about pauci-immune crescentic glomerulonephritis, what do you need to know is there is basically this is basically what you need to know. This pauci-immune is the deposition of immune complex are basically no. You don't have evidence of deposition of immune complexes. Like in anti-GBM, you have basically evidence of deposition of immune complex, but in this there is no deposition of immune complex, नहीं होता है, ठीक है. So these are basically, they can be renal limited diseases, okay. Pauci-immune crescentic glomerulonephritis can be renal limited diseases, or they can also combine these systemic small vessels, okay. So mostly those vasculitis, small vessel vasculitis are associated with this pauci-immune crescentic glomerulonephritis, okay. So when I talk about vasculitis, so when I talk about this small vessel vasculitis, I need to know that they can be pauci-immune immune crescentic glomerulonephritis, okay. So that you need to no. See, approximately 80 to 95% of the patient with active untreated pauci-immune crescentic glomerulonephritis are found to be NCA positive. So this is again very important thing. So whenever you think that when you don't see any type of immune complex or IF deposition in a kidney disease, okay, then what you need to do, you need to do NCA, okay. So they can, because 85 to 95% of crescentic glomerulonephritis, post-immune crescentic glomerulonephritis are NCA positive, okay. So that again you need to know very well, NCA positive. Okay, so this is very important thing, you need to know NCA positive. So now post-immune glomerulonephritis, when I talk about post-immune glomerulonephritis, they are prevalent in older age patient, okay. As I said, GBM, Good's Pasture syndrome, they can be in children also. 20 to 60 years is the peak years about in anti-GBM glomerulonephritis, and here they are mostly present in older patient, and most common cause for renal component of, and they are also very most common cause of for the renal component of pulmonary renal vasculitis syndrome, okay. So this is very much important. Again I said this is pulmonary renal vasculitis syndrome associated this post-immune glomerulonephritis, okay. Now what does it includes? Basically when I say about post-immune, so what you need to know is, wait, I will just add one thing over here, add one slide here. So when I talk about post-immune, what I should know is, what you need to know is, so basically I am talking about post-immune. So I am talking about post-immune glomerulonephritis, okay. So glomerulonephritis. So in post-immune glomerulonephritis, what I need to know is there can be three types, okay. So one you have necrotizing granuloma. Okay, so basically the other also, okay, granuloma is present, okay, granuloma is present, and another there is basically no granuloma, okay. So basically necrotizing granuloma, granulomatous, or this is necrotizing granulomatous inflammation if present, granulomatous inflammation is present. Then if there is no asthma, you see asthma is present or not. If there is no asthma, then you go towards, basically you go for granulomatous polyangiitis, okay, polyangiitis, granulomatous polyangiitis, that is Wagner's granulomatous, okay, that is Wagner's. Then you have, if you have granuloma, and you have asthma plus eosinophils, if your eosinophils have increased, okay, then you say it as Sturge-Strauss, okay, you say it's Sturge-Strauss disorder, okay, syndrome. So that is again very important, okay. So this is Sturge-Strauss syndrome. Then if you have no granuloma, there is systemic vasculitis is present. So this systemic necrotizing of small vessels is present, vasculitis of small vessel is present, and basically you can have asthma, then that is basically MPA, microangiatic polyangiitis, okay, microscopic polyangiitis. So that is important in case of post-immune glomerulonephritis. So this is same thing here, what microscopic polyangiitis. So what does this include? So NCA positive, so they include granulomatosis with polyangiitis, okay, GPA, where you can see granulomatosis. So here you will have granuloma. In fact, this will have granuloma and this will have granuloma, okay. But in this you don't have asthma. In this you don't have asthma. In this you have asthma plus eosinophil, okay, plus eosinophil. So in Sturge-Strauss syndrome, so that you need to know. In microscopic polyangiitis there will be no granuloma, okay, granulomatous inflammation will not be present, asthma will be present. So this is basically explaining you different types of this crescentic glomerulonephritis, post-immune crescentic glomerulonephritis, okay. So you just you diagnose post-immune crescentic glomerulonephritis this way, okay. So these are three types: Wagner's granulomatosis. And when I am talking about this thing, when I am talking about post-immune glomerulonephritis, what do you need to know? Okay, then you need to link your vasculitis, okay. So this obviously this table, or what is this graph, basically is very important, and this can have one question straight from this graph also. So what do you need to know? Vasculitis are defined as this, like large vessel vasculitis, medium sized vessel vasculitis, and small vessel vasculitis, okay. So that is very much important. In large vessel vasculitis you have giant cell arteritis and Takayasu arteritis. In medium sized vasculitis you have polyarteritis nodosa and Kawasaki disease, okay. So this is what, this classification is very much important in case of vasculitis. So small vessel vasculitis are basically ANCA positive and non-ANCA positive. So what we are dealing here is this ANCA associated glomerulonephritis. Okay, so that is Wagner's granulomatosis, microscopic cholangitis, Churg-Strauss syndrome, and drug induced. So these are the 4 important ANCA associated small vessel vasculitis. And in non-ANCA associated, you have a lot of diseases like paraneoplastic small vessel vasculitis, inflammatory bowel disease vasculitis, and you have another many immune complex small vessel vasculitis that are like HSC, HSP, cryoglobulinemia, lupus vasculitis, rheumatoid arthritis, Good's-Pasteur syndrome, Sjogren disease, drug-induced immune complex vasculitis, Behçet's disease, and infection-induced immune complex vasculitis. So these all are basically non-ANCA associated. Okay, so you need to remember ANCA associated glomerulonephritis. That is very, very important. And again, remember that that is you need to know. Now next thing what you need to know is basically you can just add, I am just integrating. ठीक है, ये आज के टॉपिक से रिलेटेड तो नहीं है, बट ऑब्वियसली इफ यू रिलेट दिस थिंग, इस चीज़ को यहीं पे रिवाइज कर लो क्योंकि ये इंपॉर्टेंट चीज़ है. सो व्हेन आई टॉक अबाउट एनका, व्हेन आई टॉक अबाउट एनका, so you need to know that there is C-ANCA and P-ANCA. This is another important thing. Okay, so C-ANCA basically it is cytoplasmic and P is perinuclear. So this is cytoplasmic and this is perinuclear. Okay, this is perinuclear, or some use nuclear also. So basically it is perinuclear. Now C-ANCA, basically the C-ANCA is antibody directed against proteinase. Okay, so we call it PR3-ANCA. So C-ANCA we also call it PR3-ANCA because it is directed against proteinase. It is directed against proteinase 3. Okay, it is directed against proteinase 3. P-ANCA, it is also MPO-ANCA. It is NPO-ANCA. Okay, so because it is directed against myeloperoxidase. Okay, it is directed against myeloperoxidase. Okay, so this is again important thing which you need to know, directed against myeloperoxidase. So this P-ANCA or P-ANCA, which is MPO. So MPO, so this MPO are directed against myeloperoxidase, hence this is microscopic polyangiitis, MPA. Okay, this is microscopic polyangiitis, is P-ANCA. And the remaining, this Wagner's, okay, PR3, when you talk about PR3, so when you write 3, you just write this W, so this is Wagner's. Okay, this is Wagner's glomerulonephritis. So basically this Wagner's glomerulonephritis is C-ANCA. Okay, now you are remained with what is remaining. So you are done with Wagner's, you are done with microscopic polyangiitis, you are remained with Churg-Strauss glomerulonephritis. So this Churg-Strauss glomerulonephritis, it can be C-ANCA, it can be P-ANCA. Okay, this is it's a variable one. Okay, this is a variable one. So this you need to know. These are the, so this is basically the revision of ANCA type, the revision of vasculitis, type of vasculitis, okay, and revision of basically ANCA associated small vasculitis. I have already explained how do you diagnose obviously this ANCA associated clinically. Okay, clinically I have not talked about I have not said about the biopsy. Okay, I have not said about the biopsy in the renal, how do you diagnose. So renal also, now it very specifically you know that there are no immune complex deposition. Okay, there are no immune complex deposition, and hence you do ANCA and you diagnose that way. See, so this basically you do IF, and when you don't see any immune complex deposition, obviously then they can be ANCA positive. So you see the ANCA, and if they are ANCA positive, you are done with that. Now this again explain a better way. So these are basically vessels. Okay, these are the large vessels, these are the small vessels, these are small vessels, and this is the medium sized vessels. Okay, so basically small your large vessels are granulomatous arthritis in patient. If you have granulomatous arthritis in a patient greater than 50 years, then it is basically giant cell arthritis. If there is a granulomatous arthritis in a patient less than 50 years, then that is Takayasu arthritis. Okay, so that again you can diagnose this way. Then again you have medium sized vasculitis. So medium sized vasculitis is polyarthritis nodosa. So polyarthritis nodosa is basically necrotizing arthritis without mucocutaneous lymph node syndrome. If there are no mucocutaneous lymph node syndrome and you are seeing necrotizing arthritis, that is polyarthritis nodosa. If you are seeing necrotizing arthritis with mucocutaneous lymph node syndrome, that is Kawasaki disease. Okay, so that again is very much important. Now in small vessel vasculitis, so the small vessel vasculitis is often ANCA, that is paucity of vascular immunoglobulin, or there is lot of immune complex deposition. When there is paucity of immune complex deposition, that is basically ANCA positive. So ANCA positive, if this is vasculitis, okay, with no asthma or granuloma, it is microscopic polyangiitis. If there is granuloma but no asthma, this is granulomatous mitosis with cholangitis, and if there is eosinophilia, asthma and granuloma, that is Churg-Strauss syndrome. Okay, and in basically immune complex depositions, okay, immune complex deposition, they can be like SLE or rheumatic arthritis. Okay, it can be IgA dominant vessel wall deposits, that is Hirschsprung HSP, Henox-Scolen purpura, or there can be, if you see cryoglobulins in the blood, so when you see cryoglobulins in the blood, it can be cryoglobulinemia, and other source, which is other immune complex vasculitis, can occur. So this is basically approach, how do you approach or how do you diagnose a vasculitis. Okay, so importantly, I have completely covered your vasculitis also. I have covered your basically CGN also. Okay, so you need to learn at once, don't go again and again and read same thing. Okay, so you need to learn at once everything. See, so this you need to know. Now coming back to the topic basis, so what are the clinical symptoms of this pauci-immune glomerulonephritis? So basically pauci-immune, it is rapidly progressive, so this acute renal failure, they will also present with acute renal failure, obviously rapidly progressive, usually with nephrotic syndrome, and renal limited or associated with systemic vasculitis. Okay, they can be renal limited or they can be associated with systemic vasculitis, which we have already described. Light microscopic feature, so basically there will be crescent, okay, crescent, and there will be necrotizing glomerulonephritis, which can be diffuse or focal. Now again I said crescents, they can be segmental glomerular tufts, necrosis, and can show fibrin exudate, we have already talked about. So crescent, they can be associated with fibrin exudates. Okay, we have talked about, I have shown you figure also. There can be associated with interstitial nephritis, composed mainly of lymphocytes and macrophages. Okay, so now immunofluorescence is normally negative or non-specific finding. Okay, you can see fibrinogen is frequently found in the crescents. Okay, EM, so EM, as I already said, there can be just electron deficient, there is no deposition of electrodense deposits. Okay, there is no deposits, but yeah, you can see rupture or gaps in GBM, can be seen. Okay, so this is electron microscopic feature in case of pauci-immune glomerulonephritis. Now, so this completes our pauci-immune glomerulonephritis. We have already done other IgA nephropathy or minimal change disease, okay, or membranoproliferative glomerulonephritis, or even lupus. So we have done other. So type 2 we have done, mostly type 2 we have already done, so I am not including type 2 here. Now another important thing you need to know is diabetic nephropathy. When we are talking about glomerular disease, diabetic nephropathy is again very much important, and this diabetic nephropathy is basically associated with your proteinuria. Okay, so diabetic nephropathy is basically associated with your proteinuria. What do you need to know about diabetic nephropathy? Is the first thing you need to know is proteinuria. They will be presenting as nephrotic syndrome also. They are part of your nephrotic syndrome. Okay, secondary cause of nephrotic syndrome like minimal change disease, focal segmental glomerulosclerosis, or membranoproliferative glomerulonephritis, they are the primary cause of nephrotic syndrome, but diabetic nephropathy is secondary cause of nephrotic syndrome. So that you need to know. Okay, so renal disease, they are basically caused by now you know very well, diabetic nephropathy defined as renal diseases which is caused by diabetic nephropathy type 1 and type 2, which includes thickening of the glomerular basement membrane, expansion of mesangium, nodular diabetic glomerulosclerosis, arterial hyalinosis, and arteriosclerosis. Okay, so these are the most important points which you need to know in diabetic nephropathy: thickening of GBM, expansion of mesangium, nodular diabetic glomerulosclerosis, arterial hyalinosis, and arteriosclerosis. So these are basically 5 things which need to be understood or which you need to remember in case of diabetic nephropathy. Okay, now remember, now the point for the MCQ is basically expansion of mesangium. So this mesangial expansion due to how do mesangium is due to accumulation of extracellular matrix. It relates with clinical manifestation of diabetic nephropathy. Okay, so this will relate with the clinical manifestation of diabetic nephropathy. So this is important thing. So which of the following is true? So this basically thickening of GBM represent clinical manifestation of diabetic nephropathy? No. Expansion of mesangium represent clinical manifestation of diabetic nephropathy. So this you need to know. This line is important for your MCQ in coming exams. Okay, so diabetic nephropathy, you need to know that within 1 to 2 years, 2 years after the onset of clinical diabetes, morphological changes appears in the kidney in case of type 2 diabetes mellitus, because type 2 diabetes mellitus we never know कि from when it started, okay, कहाँ से शुरू हुआ था पता नहीं होता है, इसलिए within 1 to 2 years normally you see the morphological changes starts to appear in the kidney. Okay, so remember again this is an MCQ line. So as I said, clinical correlation with the clinical diabetic nephropathy, clinical presentation of or clinical manifestation of diabetic nephropathy. So remember what will which will help, expansion of mesenterium will obviously help you that. Okay, so now which will correlate, expansion of mesenterium will correlate with clinical manifestation of diabetic nephropathy. Now remember this line is again important. Thickening of GBM. Now thickening of GBM is a sensitive indicator for the presence of diabetes. So when GBM is thickened, so you can say that obviously diabetes is present, but it correlates poorly with the presence or absence of clinically significant nephropathy. Okay, so thickening of GBM is a very sensitive indicator of diabetes, but poor indicator of clinical significant nephropathy. But expansion of mesenterium is basically a good correlation, it correlates good with the clinical significant nephropathy. That this line is important for your examination point of view. Okay, so remember another important thing, that is loss of heparin sulfate. So now again basement membrane, we have talked about basement membrane have collagen, your laminins, okay, lamins, and you have heparin sulfates. So basically this loss of heparin sulfate moiety, this heparin sulfate basically are responsible for the negative charge. Okay, so when this heparin sulfate are lost, so negative charge is lost, so now there can be filtration of more and more amount of protein. Okay, there are more and more amount of albumins, so hence there will be increased albuminuria. So that is again very important feature which you see in diabetic nephropathy. Okay, so now coming back to the pathogenesis. So basically the pathogenesis is multifactorial in this case, multifactorial, but the most important factor is you are not under your glycemic control. Okay, diabetes is not under your control. Okay, so basically hence hyperglycemia is one of the important cause of diabetic nephropathy, both in case of type 1 and type 2. Okay, so this is important. It is proved by that when you remove your pancreas, okay, when you remove your pancreas or when you transplant pancreas in the case of hyperglycemic state, then obviously you see there is regression in diabetic nephropathy lesion. Okay, so hyperglycemia is one of the most important pathogenic factor in case of diabetic nephropathy, that you need to know. Now how hyperglycemia is one of the important factor. So basically hyperglycemia results in accumulation of advanced AIDs, okay, that is advanced glycosylated end products. So there results in accumulation of AIDs, that is AIDs are advanced glycosylated end products. Why? Because of non-enzymatic glycosylation of the proteins. Okay, so they will result into non-enzymatic glycosylation of the proteins. Okay, and because of glycosylation of the proteins, they will result into advanced glycosylated end products. Okay, and this AIDs will affect many proteins including GBM, collagen, and other matrix proteins. Okay, so this will result into damage of the glomeruli. Okay, then obviously what these A's are doing, so A's will result into injury and remodeling. So what they do, they promote protein cross-linking, they will stimulate synthesis of growth factor, so growth factor, hence there will be like Crescentic formation या fibrosis. So in glomerulosclerosis जो हो रहा है because of this stimulation of growth factors by the A's. Okay, so like tumor growth factors beta, insulin growth factors, vascular endothelial growth factors, they cause increased intracellular matrix production, and obviously binding of AIDs to cell surface receptors increase intracellular, so there will be increase in oxidative stress also, and hence there will be injury to the cells. Okay, injury to the cells, and they can undergo necrosis or fibrin deposition can undergo, and basically there will be podocytopenias. Okay, so podocytopenia, so basically diabetic nephropathy are also associated with podocytopathies also, they are included. So there will be podocytopenia by apoptosis. Now the second thing which happens is activates protein kinase C. So this hyperglycemia will also activate protein kinase C. So one, they make AIDs so they make advanced glycosylated products. Then hyperglycemia are also responsible for protein kinase C activation, and this activation of protein kinase C will lead to activation or increase of diacylglycerol, okay, DAG, fructose, and production of sorbitol, and this will again increase matrix production, okay, they will again matrix production increase होगा, इसीलिए sclerosis होता जाता है, sclerosis बढ़ाता जाता है. And the third thing which this increase hyperglycemia, the third thing which increase hyperglycemia will do is basically it will induce defect in mitochondrial electron transport, okay, so mitochondrial electron transport में increase हो जाएगा. So now this increase in mitochondrial electron transport will result into elevated nitric oxide and superoxide production, okay, so free radical injury होने लग जाएगा, there will be vasodilation and oxidation, and obviously there will be increased reactive oxygen species and oxidative stress, and this will again result into tissue damage. Go to your general pathology, okay, oxidative stress or ATP damage, mitochondria damage कैसे cell injury कर रहा है, we have already explained about that, okay, in detail. So that is again very much important in case of injury over here. So that will also result in the injury to the glomeruli, okay. Then another factors are genetic factors. So genetic factors, basically the genetic factors which are responsible are like renin-angiotensin system genes such as angiotensin converting enzymes, angiotensinogens, angiotensin 2 and type 1 receptors. So these are all responsible for increasing chances of diabetic nephropathy, okay. Again the insulin resistance genes like PPARG2, glucose transporter 1, apolipoprotein E, they are also responsible for increasing diabetic nephropathy. And again super dismutase 1 gene, CCR5, CNDP1 genes, these all are the different types of gene which are responsible, or different genetic factors which are responsible for diabetic nephropathy, okay. Now again another important factor which is responsible for diabetic nephropathy can be the cardiovascular or hemodynamic factors, okay. So basically cardiovascular or hemodynamic factors, they what again they do, so they don't do anything but they again increase this transforming growth factor beta 1 expression, okay, and again they increase the extracellular matrix accumulation, okay. So these are again important in case of, and again this like systemic hypertension, they will increase may aggregate progression of diabetic nephropathy by angiotensin 2, okay, by angiotensin 2 they can, and obviously endothelial dysfunction also can result into development of this diabetic nephropathy. So that is again very much important in case of development of diabetic nephropathy, okay. So how this are occurring, so basically you need to know that extracellular matrix. So in cardiovascular there will be, so this firstly this extracellular matrix accumulation, okay. So whenever there is extracellular matrix accumulation, so diabetic mellitus will promote this extracellular matrix. So this extracellular matrix when it's promote, what there will be loss of autoregulation. So the autoregulation का loss हो जाएगा, there will be loss of autoregulation, and this loss of autoregulation will result into hyperfiltration, okay. This will result into hyperfiltration, okay, there will be hyperfiltration, and hence there will be increase in capillary pressures, okay, capillary pressure, and when there is increase in capillary pressure, what this will do, this will cause into glomerulomegaly, okay. So this will cause in glomerulomegaly. So one of the finding in diabetic nephropathy is glomerulomegaly, and glomerulomegaly is because there is diabetic mellitus, diabetic mellitus promotes extracellular matrix accumulation, okay. So extracellular matrix accumulation because of glomerular hyperfiltration, so that you need to know. And then there will be angiotensin 2. So this angiotensin 2 will, what it will do, angiotensin 2 will increase GFR, it will increase basically GFR, so basically permeability, okay, and this will result basically by a constriction of efferent arterioles. They will result into constriction of efferent arteriole, and that will increase again GFR will be increased, and hence that the increase in GFR will again increase in extracellular matrix accumulation, and again that extracellular matrix accumulation will result into glomerulomegaly. And obviously endothelial dysfunctions, this endothelial dysfunctions will result into this occurs because of obviously oxidative stress and all. So basically the reactive oxidative scans, reactive oxygen particles, they will result into endothelial dysfunction. So these are some of the important cause of your what you call it diabetic nephropathy. The hypoglycemia, okay, hypoglycemia, the cardiovascular and hemodynamic factor. So these all are important factors for the development of your diabetic nephropathy or pathogenesis of diabetic nephropathy. As I said, podocytopenia can also occur. So this is again because of oxidative stress, age factors, fatty acids, and obviously because of PPAR, okay, paroxysmal proliferative activated receptors. You can this can be detected by WT1 immunohistones, okay. So immunohistochemistry can be done in case of diabetic nephropathy, and you do WT1, and WT1 will highlight this podocytopenia. And obviously podocytopenia will is correlating with your proteinuria, hence this disease is also this disease is associated with nephrotic syndrome because of this podocytopenia, okay. Now other factors which can result into this diabetic nephropathy is smoking, hyperlipidemia, obesity, and low vitamin D levels, okay. So these are other factors which are responsible for this diabetic nephropathy. Remember, low vitamin D level can be asked in your exam, okay. So now how do they present? Very much important. There are so many MCQs are asked over here. So the earliest manifestation is microalbuminuria. ये आपका MCQ हो गया. So earliest manifestation is microalbuminuria. The earliest manifestation of diabetic nephropathy is microalbuminuria. Okay. So now you need to know microalbuminuria का मतलब क्या हो गया? Albuminuria of 30 to 300 milligram per day or microgram per milligram creatinine. Okay. In case of microalbuminuria. Now remember, this microalbuminuria, it occurs greater than 5 or greater or equal to 5 years after onset of diabetic mellitus. So it usually occurs more in greater than 5 years region, okay. And this, what they do, they predict loss of renal function and is associated with progression to end-stage renal disease. Note, degree of glomerular hyperfiltration correlates with subsequent risks of clinically significant nephropathy. Okay, so risks of clinically significant nephropathy is associated with decreased glomerular hyperfiltration, decrease of glomerular hyperfiltration. Okay, now what do you need to know here? Another thing you need to know is basically this is a table from your Harrison's, and obviously it is saying about the different normal values of albumin secretion, okay. And obviously when do you call it microalbuminuria and when you call it proteinuria, okay. So microalbuminuria is basically 30 to 300 milligram per 24 hour, and basically if it is greater than 300, then you tell it is a proteinuria, okay. In case of albumin creatinine ratio, or you say milligram per gram of creatinine ratio, in that condition again microalbuminuria is 30 to 300, but in case of proteinuria it is greater than 300 and less than 30 is normal. In case of dipstick proteinuria, microalbuminuria means that is negative trace or 1+, and proteinuria is when you have 3+, okay, dipstick. And basically in 24-hour protein, that is milligram per 24 hour, we don't have presentation of microalbuminuria, but if that is greater than 150 milligram per 24 hour, that is proteinuria, and less than 150 milligram per 24 hour is normal, okay. So remember, microalbuminuria is a potent risk factor for cardiovascular event and death in a patient with type 2 diabetes mellitus. So again, this is an MCQ, and basically a patient normally he can succumb to cardiovascular events before proteinuria, they progress to proteinuria. So from microalbuminuria they will reach to proteinuria. Before that, reaching to proteinuria, a patient can show the cardiovascular events, okay, he can show the cardiovascular events. And proteinuria, that is more than 300 milligram albuminuria, you will see that after 5 to 10 years after the onset of early albuminuria. So after the onset of early albuminuria, you can see proteinuria only after 5 to 10 years, okay. So that is again important MCQ you can see in your exams. So now the testing protocol. So currently recommended testing protocol for type 1 diabetes mellitus for microalbuminuria is 5 years after diagnosis of diabetes and then yearly afterward. And because time of onset in type 2 is unknown, so what you do, you just do microalbuminuria whenever you are checking a type 2 diabetes mellitus patient, and after that you do yearly, okay. So that is important factor you need to do in microalbuminuria cases in case of diabetes mellitus, okay, in type 1 and type 2. Now that was microalbuminuria. Now proteinuria basically it can be variable, okay. Frank diabetic nephropathy, proteinuria can be like from 500 milligram to 25 grams, so it can be very high amount of protein can be secreted, okay. So often associated with nephrotic syndrome. And remember, more than 90% of the patient will present of type 1 will present with diabetic retinopathy, okay, in case of the type. So diabetic retinopathy is more common in case of your type 1 diabetes mellitus. If in case of type 1 diabetes mellitus, if you are not seeing diabetic retinopathy, then think that is not type 1. Okay, so absence of retinopathy in type 1 patient should with proteinuria should prompt consideration of a diagnosis other than diabetic nephropathy. Okay, you need to remember that. Now remember, only 60% of the patient with type 2 diabetes mellitus with nephropathy have a diabetic retinopathy. Remember that. And significant correlation between the presence of retinopathy, and there is a correlation between presence of retinopathy and Camilstone-Wilson's nodule also. Okay, so if retinopathy is present, Camilstone-Wilson nodule, or if Camilstone-Wilson nodules are present in case of nephropathy, then retinopathy, chances of presence of retinopathy is also high. Okay, so this is what about proteinuria you need to remember. So proteinuria you need to remember that the more chances of diabetic retinopathy is in case of type 1 with retinopathy, with nephropathy. Okay, type 1 with nephropathy have more chances of diabetic retinopathy than type 2 with diabetic nephropathy have less chances of diabetic retinopathy. Okay, so that you need to remember. Now another thing you need to know is characteristically advanced diabetic nephropathy have, so when you talk about advanced diabetic nephropathy, the kidney is basically either enlarged or it is normal. Okay, so this is another important clinical scenario, and hence in diabetic nephropathy you don't require to, because biologically in biochemistry you can see microalbuminuria, you can see proteinuria. Okay, so you can see all those things, and obviously your kidney is basically, in most of the glomerular disease, kidney will obviously shrink down, but in case of diabetic nephropathy, kidney will be enlarged. Okay, morphologically. So that is again very important thing, because in most of the glomerular disease kidney sizes usually decrease. So that is again very important thing. Clinically you can say, okay, this is diabetic nephropathy. Okay, so basically after onset of proteinuria, the renal function will start declining, with 50% of the patient reaching renal failure over 5 to 10 years. So the from earliest stage of microalbuminuria, it usually takes 10 to 20 years to reach at the end stage renal disease. Okay, and you can also see other findings. You can see acute pyelonephritis with papillary necrosis can occur, and also there can be microhematuria can occur in this case, and they are also associated with papillary necrosis and nephrocalcinosis. Okay, so diabetic nephropathy are also associated with papillary necrosis and nephrocalcinosis. So these are important clinically. Okay, laboratory test, what you do is hemoglobin HbA1c you do, or you can do cystatin C. Okay, so to monitor renal function decline. Macroscopically, I have already said the kidney are bilaterally enlarged. Okay, so end stage kidney disease, they can be normal or slightly only small. Okay, in case of diabetic nephropathy, you can see cortical scars which may be present because of hypertensive renal disease or pyelonephritis, and there can be loss of pyramids which indicate papillary necrosis. Okay, so I have already explained what are pyramids, and obviously that there will be loss of pyramids which will indicate the papillary necrosis. Now microscopically, what are important, as I already said, the earliest change is diffuse GBM thickening, but remember this GBM thickening doesn't correlate with the clinical manifestation of diabetic nephropathy. So basically this can present even in the absence of proteinuria cases. Okay, and basically GBM thickening is basically not detected by your light microscopy, you need your EM. Okay, it can be detected by light microscopy only when it is greater than 4 times. Okay, then there can be glomerulonephritis. I have already explained, there can be glomerulonephritis in this case. Okay, because of extracellular matrix expansion, and there can be mesangial expansion and sclerosis. So this is very much important. The mesangial expansion is related with the clinical manifestation of diabetic nephropathy. Okay, so this is related with clinical manifestation of diabetic nephropathy. Diffuse mesangial hypercellularity will be seen in early phases, and there will be accumulation of type 4 and 6 collagen, laminin and fibronectin in that sclerosis portion. Okay, so here this image is showing of mesangial hypercellularity. See, this is a mesangial region. Obviously this is showing mesangial hypercellularity. I have already explained you again and again about the glomeruli. So these all are the capillary loops. Okay, these all are the capillary loop. This is Bowman's capsule space, this is Bowman's space, and here you can see mesangial cellularity. Okay, so this mesangial cellularity is very much, you can see. So basically you are seeing mesangial cellularity, and then you can, this is basically your fibrin deposition and all are seen. Okay, and in this so this is basically more than fibrin deposits, they are like hyaline drops. Okay, they are hyaline insudation, you say hyaline insudation. So this is hyaline insudation can be seen here. So here also you can see hyaline insudation. Okay, so this is hyaline insudation. So again this is showing you sclerosis. Okay, this is showing you sclerosis, and this is showing you hyaline insudation. Okay, arterial hyalinosis, arteriolar hyalinosis, hyaline, arteriolar hyaline is seen over here. This is arterial hyaline. Okay, so now very much important, you see Camel-Stein-Wilson nodule in case of diabetic glomerulosclerosis. So they are basically the round to oval messenger lesion with acellular matrix core with peripheral spar crescent shape mesangial nuclei. Okay, so they are pass positive and also Jones methamine silver positive, but negative for Congo red, because such type of acellular matrix can be amyloidosis also. Okay, such type of acellular matrix can be amyloidosis also. That nodule can be formed by amyloidosis also. Okay, so these are the nodules. Okay, these are the nodules. So these nodules are basically Camel-Stein-Wilson's nodule. Okay, now coming to the other things which you can see microaneurysm. So you have already seen hyaline, insudations. You can see hyaline insudations in glomerular capillary wall that are known as fibrin caps. They are called as fibrin caps. Okay, and also you can see capsular drops. Okay, so these capsular drops, they are absorbed between the parietal epithelium and the Bowman's capsule. So you can see capsular drops, you can see fibrin caps, you can see Camel-Stein-Wilson nodules. Okay, and remember these capsular drops, they are the characteristic of diabetic nephropathy, but they are not specific. Okay, they are characteristic but not specific, that you need to remember in case of capsular drops. Okay, so you can see microaneurysm. So this is what you are seeing, microaneurysm, and this is a nodule. Okay, this is Camel-Stein-Wilson nodule. This is again Camel-Stein-Wilson nodule. So this is basically sclerosis which is increasing more and more sclerosis is increasing in case of nodular sclerosis. So late stage nodular sclerosis. Okay, there can be segmental sclerosis and late segmental and obviously nodular sclerosis in case of diabetic nephropathy. Okay, so that was about the glomeruli. In tubules, what you can see, in tubules you can see prominent protein reabsorption and lipid droplets. Okay, you start seeing lipid droplets in proximal tubules. Okay, in case of proteinuria, tubules can undergo atrophy and there can be interstitial fibrosis. Okay, there can be, and tubular basement membrane also show thickening, they also show thickening, and there will be also excess collagen deposition in that. And in case of acute diabetic ketoacidosis, proximal tubules can contain abundant clear vacuoles, okay, of glycogen, and that is known as Ehrmann-Eberstein lesion. Okay, so that is known as Ehrmann-Eberstein lesion. So this is again important, Ehrmann-Eberstein lesion are also seen in tubules of diabetic nephropathy. Okay, Ehrmann-Eberstein lesion is seen in tubules of diabetic nephropathy. So these are Ehrmann-Eberstein lesion. So you see this vacuolization, यहाँ पे vacuolization, ये tubule है और tubule का vacuolization हो रहा है ना. So this vacuolization is basically your Ehrmann-Eberstein lesion. Okay, so this is your PCT, normal PCT, eosinophilic cells, brush borders दिख रहा है. But this PCT there, here you can see in the PCT you can see this, there is vacuolation. So ये vacuolation Ehrmann-Eberstein lesion कहते हैं, ये tubules में दिखता है. ठीक है. Arteries, so basically arteries, large arteries including proximal intratubular and arcuate artery, they will show intimal fibrosis, and there can be atherosclerosis, there will be arteriosclerosis. Okay, arterioles, there will be arteriolar hyalinosis can be seen, which I have already shown in the image. Okay, so immunofluorescence. So immunofluorescence, again DAD is MLA, you know very well. Okay, so basically this DAD, diabetic nephropathy, so this is linear capillary. So basically IF is linear capillary. So IF will be linear capillary of IgG and albumin. Okay, this is IgG and albumin, and obviously EM, electron microscope, there will be diffuse thickening of basically GBM. There will be diffuse thickening of GBM, and there can be podocytopenia which will result into effacement of the food processes. Okay, so this image is showing linear IgG deposition. So here you can basically see, so these all are the capillary loop and linear IgG deposition which can be seen in case of diabetic neuropathy. Okay, and obviously this is a basement thickening. See here, this basement membrane have thickened up. So this is basement thickening. You can see basement membrane thickening in case of diabetes mellitus. Okay, now you can also classify diabetes mellitus into type 1, 2, class 1, class 2, 3 and 4. Okay, so class 1 basically it is isolated GBM thickening, you can see. Class 2 you are seeing mesangial expansion also, obviously, and with mild mesangial expansion or severe mesangial expansion. Then in class 3 you see nodular sclerosis or Camel-Stein-Wilson lesion. So Camel-Stein-Wilson lesion are seen in class 3, and basically in class 4 you see advanced diabetic glomerulosclerosis. Okay, advanced glomerular nodules you can see in class 4. So this is different way you can define diabetic nephropathy as class 1, class 2, class 3 and class 4. And class 3 is where you see Camilstone Wilson lesion. Okay, class 4 is where you see advanced diabetic glomerulosclerosis. Okay, so with this much of information regarding diabetic nephropathy and about the Crescentic glomerulonephritis, we complete today's topic. So basically there are a lot of questions which can be asked from diabetic nephropathy and obviously Crescentic glomerulonephritis, and basically I have interlinked also. So hope you understood this very well, and basically I have taught all the basic things. Okay, the basic things अगर आपको पता है तो now you just you know very well कि हाँ आपको कैसे करना है फिर what you are basically सबसे important चीज़ है कि you should know how you need to study. The method of study will help you. आपको जैसे method आपको पता है, आपने basic चीज़ों को पहले पढ़ा है, now that apply those basic things in your each and every type of topic, and basically आप इंटीग्रेट करके पढ़ो, है ना, इंटीग्रेट करके पढ़ो. जैसे कि अब डायबिटिक नेफ्रोपैथी का आप हैरिसन्स में जाके ट्रीटमेंट पढ़ दो. I have taught most of the thing of diabetic nephropathy. There is left is treatment. So treatment is basically glycemic control is most important. So आप अगर glycemic control रखोगे, so that is important. But if you are not able to control glycemic control नहीं कर पा रहे हो, तो basically then renal transplant is your another option. So you need to go and read in your Harrison about the treatment part, और इसको पूरा एक ही बार में complete कर दो. Maximum other things which are written in Harrison I have covered that. Okay, so you need not to worry. जो कि lines आपको MCQ में पूछ सकते हैं वो भी मैंने cover कर दिया है. So this way we complete today's topic. And I would like to thank you all for bearing me this long, and I would like to request you, please subscribe our YouTube channel. Okay, subscribe this Unacademy YouTube channel, and just after subscribing try to hit the bell icon also, so that you can get notification. Okay, hit the bell icon. So you can also contact us at the Telegram channel. Okay, and basically you can use my promo code to get subscription as ANLIV. This is my promo code, and basically I would like to again say, this is Unacademy and we help you to crack, because our motto, our main line is let's crack it, and we together will help you to crack it. Okay, so we'll help you to crack NEET PG. So please join us, please join our family, please subscribe our family. Our family is growing day by day. We have very good faculty over here. Yeah, so basically we all the teachers and you students are one family, and that family together you can just say your problems to us. Basically we will help you regarding any type of, some of you might be depressed with some of things, so you can just share your problems, share your stories to us. Basically when you share your story, share your problem, any type of problem, okay, so we will just try to give solution to that problem, or we will try, basically if you are not able to so provide solution to your that problem, at least we will help you to keep that problem aside and help you to crack what is your aim. Okay, so to crack NEET PG is your aim, and we will help to crack that. Thank you very much. See you in next class. So